Hi, McMaster Alzheimer's Society. We have with us today Dr. Namasivayam-MacDonald, who is a clinically trained pathologist and associate professor at the School of Rehabilitation Sciences at McMaster. How are you doing today?
Good, how are you?
Great.
What inspired you to focus your research on dysphagia and look into its connection with dementia?
So, during my clinical master's degree, I had a clinical placement at Toronto Western Hospital on the general internal medicine unit. And before that, I just assumed I would be working with kids because most speech language pathologists do, or so I thought at the time. And I had this really amazing opportunity to work with all these older adults, many of whom had cognitive impairments. And in acute care, most speech language pathologists really work on swallowing. So in working with those patients and understanding their needs and seeing that they're unique to so many other types of older adults and different disorders that we come across, like stroke, for example, or brain injury, it really inspired me to focus on that population. But also, I realized that there wasn't a lot of research in swallowing and dementia. They had kind of been written off before because of their cognitive impairment. So people just assumed because they couldn't participate or they thought they couldn't participate, how would you even do a swallowing assessment? How could you do intervention with them? So I was really interested and intrigued to work more with them and see what we could do and what we could learn.
What are some of the common challenges faced by the caregivers of individuals with dysphagia?
Yeah, so I mean, a lot of that caregiver burden work is inspired by my own lived experiences. So when I started my PhD, my research was actually on malnutrition and dysphagia. So, really taking a holistic approach to care. So, it was always I always had this idea that there's many factors involved. We can't just look at dysphagia or one body system. But concurrently, my grandfather was quite sick, and my grandmother started looking after him. And I just saw how much of a toll it took on her, and it became really evident that there were no supports. So, towards the end of my doctoral studies, I really wanted to differentiate myself from my supervisor, and I just thought I'd do a little side project, a passion project, really, to better understand caregiver burden when taking care of someone with a swallowing impairment, which my grandfather had, and no one had done it before. So I just did a systematic review, which I thought, okay, I'll just do it for fun and see how things go. And it ended up being this huge area of my research and really the main focus now. And I just think it's so important because, like I said, these caregivers don't have supports. We assume their needs. And what the research does show in terms of caregiver burden or the caregiving experience in general is that the health of the caregiver directly affects the health and well-being of the care recipient. So it's kind of like the idea of you need to put your oxygen mask on for yourself first in case of an airplane incident, and then put it on for your child, right? Like, you need, as a caregiver, we need to take care of ourselves. And I think so often as clinicians, we kind of forget that we have the best intentions and we want to take care of our patients, but we don't realize that supporting our caregivers will help to optimize those outcomes for our patients.
How can we better support caregivers and families affected by dementia and dysphagia?
I think in general, what I've learned is that we can't assume anything about caregivers. I was just talking to a colleague the other day, and we were saying that some caregivers are so shocked by a diagnosis that they can't take anything in and they can't take anything more on. But then there are caregivers that want to do every single little thing, and they want to do the exercises and prepare the foods and do all the things. So I think the best thing we can do is ask the caregivers what supports they need, if they think they're capable of carrying out the recommendations that we're advising, especially in this current healthcare landscape where people aren't in hospital for a long time and we don't have a lot of supports in the community. So we're expecting the caregivers to do a lot, but without asking them, is this feasible for you? Is this capable? Are you capable of doing this? Are there financial constraints? Like, we don't have those conversations, and sometimes they're difficult conversations. And we also I don't think we use social work enough. Because they can really facilitate some of these conversations and help get supports. So I think the biggest takeaway is asking people what they're capable of and if things are feasible and what supports they need.
How do swallowing impairments typically manifest in older adults with dementia, and what challenges arise in diagnosing these conditions?
Yeah, so what we're learning, so we don't actually know. So there's very little research looking at dementia across the trajectory and then mapping how swallowing impairments change over that trajectory. So what we do know is that older adults in general have changes to their swallowing even in the absence of any diagnosis of any medical condition. Our just muscles get weaker, we just things look a little bit different, but they don't cause functional changes. So what our research has just recently actually discovered is that historically we thought that people just with dementia had trouble chewing and they just were forgetting to swallow. But because, as I mentioned before, we've been wary of doing instrumental assessments, more thorough assessments with these people. We didn't have the information about what else was going on in the swallow. So the gold standard assessment for swallowing disorders is an X-ray video swallow. So our team has been doing X-ray video swallows on people living with dementia, and what we've seen is, yeah, there are some issues with what we call the oral phase, so the chewing and processing of the food, but most of the issues lie in those weakness of those muscles. So they're having food and liquid stay behind in the throat even after they've swallowed. And once the airway reopens during the swallow, that food and liquid is entering the airway, going into the lungs and causing infection. So when we hear about so many older adults, especially those living with dementia, that have aspiration pneumonia and unfortunately die at end of life, it's because that food and liquid is going into their lungs. So what we're seeing is this in the beginning, some, yes, issues with forgetting to swallow, chewing, but the weakness of the muscles that's causing difficulty pushing the food down into the throat and then clearing it from the throat into the esophagus. And that gets worse and worse as time goes on. So right now, the research has really focused on early dementia, like upon diagnosis when we don't really see a lot of functional changes, and then end of life, where now the families are wondering, should we put them on a tube feed, which there's no evidence for, or should we just stop feeding them altogether? But there's nothing in this in between where we know that they need the nutrients to thrive, and we know that malnutrition actually increases their deterioration, their cognitive deterioration. So concentrating on swallowing impairments early on is actually going to improve nutrition outcomes, which can slow the progression of the disease.
How do the various types of dementia affect swallowing and function differently?
Yeah, so we're also still learning about that, just because, again, people weren't doing these comprehensive assessments previously. So, and we can't really understand what this looks like unless we do these comprehensive assessments that involve things like an X-ray.
Yeah.
But what we do know, for example, for people with frontotemporal dementia, what we've seen is they lack inhibition. So they're stuffing their mouths a lot. So a lot of those oral phase deficits, so what's happening in the mouth once you put food into your mouth, that's really characteristic of, for example, frontotemporal dementia. So I might suggest that those patients or the caregivers of those patients like really focus on cueing and like not providing too much food at once, cutting food up really small so that they're encouraged to take smaller bites and not stuffing their mouth as much. Versus something like what we've seen in like Parkinson's dementia is more of those weakness of the muscles and discoordination, which is characteristic of Parkinson's in general. So we're still learning a little bit, but when we think about the site of impairment in the brain, so where we're seeing deterioration of white and gray matter in the brain, we can map that to like, okay, so this brain area is responsible for this, so then perhaps mechanistically this is what the change we would see in the swallowing.
Are there any common misconceptions about dysphagia?
I think I don't know, that's a really good question. I think that when we think about misconceptions, I don't think people realize how complicated swallowing is. And it's something we don't really think about until we can't do it, right? So most people don't realize there are 56 pairs of muscles that are required to swallow. They don't realize that you have to stop breathing to swallow, right? We have to close off that airway.
Mm-hmm.
They don't realize that you need to coordinate the tongue with the airway, with the esophagus to swallow, right? So I don't know if it's misconceptions, but there's not an appreciation for how complicated it is and how essential it is for things like I said before, to get the nutrients you need to thrive, right? We also don't think of it as central to our socio-cultural well-being. So, you know, if you think about when you want to go hang out with a friend, you're probably going to grab a drink. You're probably going to go for a coffee. You might go to the movies and get some popcorn, right? Like all of that involves food. And if you can't swallow, you can't participate in those activities. So I think just in general, there is this lack of awareness about how central swallowing is to the rest of our lives.
How do you envision the future of dysphagia management evolving, particularly with the integration of new technologies or new therapeutic approaches?
That's a really great question. I mean, I think right now in Canada specifically, and I would say even in the United States, North America, not every person who needs this instrumental assessment gets it. And it's because it's costly to the healthcare system. It takes up time. We need a radiologist to be in the x-ray suite. There's just a lot of complicated pieces. But with the introduction of new technologies, I think we can be screening for people better. So, you know, as soon as someone's diagnosed with dementia, for example, every time they go to a memory clinic, they should be screened for dysphagia, right? And then we can triage better and also identify issues earlier on, intervene proactively, and perhaps reduce the progression of the disease by controlling nutritional status a little bit better, but also optimize quality of life for longer. So like what I foresee is this greater access to instrumental assessments, better screening tools. So now there's like really cool technologies that are being developed that you can put sensors on the throat and it can detect when food or liquid enters the lungs rather than going down to the esophagus. So integrating those into those memory clinics for a really fast and easy screening tool, which will then help us to identify impairments way earlier on and then optimize quality of life earlier on too. And the other thing I was thinking was we could also use those technologies, but also improve awareness in the multidisciplinary team, right? Like it's not just the speech language pathologist that needs to be involved here. We can increase awareness with the dietitians, with the geriatricians. Right now, most geriatricians in those memory clinics are just asking people, you know, do you have any difficulty swallowing? But someone with a cognitive impairment may not be able to answer that accurately, and their caregivers are so overwhelmed with so many other things going on. Their focus is not the nutrition. And what we're seeing is that so often people are making small changes to accommodate this change in swallowing. So for example, they're cutting their bites smaller, they're avoiding things like salads or steaks. But why are you avoiding foods? It's probably because you have difficulty swallowing. So I think a greater awareness of what a swallowing impairment looks like with really standardized screening tools that are easy for those geriatricians and reliable and valid could really change how we look at dysphagia, especially in the context of dementia.
How important are lifestyle factors such as diet and exercise in dysphagia and or dementia prevention?
Yeah, so we're learning about those still. Our lab is really interested in this. So what we found in general in frail older adults is that exercise kind of moderates the relationship between frailty and swallowing. So what that means is that people who are more physically active, even though they're frail, they have fewer swallowing impairments. But people who are less physically active have more swallowing impairments. And what I find really interesting is when we think about the dementia literature, there's also a strong connection between exercise and not even like complicated exercise, just going for a walk and improve cognitive health. So if we look at this from a holistic point of view, could we pair something like exercise to promote overall health and thinking about how it affects each body system, including swallowing? The other thing that our lab has really been focusing on lately is social determinants of health. I mean, it's a very hot and sexy topic right now, but it's so important, right? So what we've seen also here is that how does culture affect, or how is that a risk factor for swallowing disorders? So for example, what we've seen in the literature and even in our own research is Black people are less likely to report a swallowing issue. And that's when we look historically at what has happened in North America specifically. A lot of Black people have been dismissed by healthcare providers for so long. So it's not that they don't notice a problem, they just don't feel like it's worth bringing up because they're going to be dismissed. So it ends up being a risk factor, but it's a lot more complicated than you're Black, so you're more likely to get this. It's you're Black, you may be worried about how you're going to be perceived, and because of that, you don't bring up your swallowing issues, and they go on for too long, and they progress too far by the time you bring it up, and then we can't help you as much as we could if you had told us when you initially started seeing symptoms. So I think those social determinants of health are really something that we need to explore more and understand more.
How do you think public awareness and education about dementia can be improved?
Yeah, so we've actually been working with the Alzheimer's Society, the local branch of the Alzheimer's Society, to increase public awareness, specifically around meal times and mealtime changes with dementia. And once again, I just think it can be improved by making people aware that this is a thing that is going to change. Just like that their memory is going to change and their ability to communicate is going to change, their ability to eat and participate in meals is going to change. And the more awareness we can spread about that, and at a very high level, we don't need to tell everyone every single thing that's going to change, but in bringing that awareness, especially to the caregivers and loved ones that surround these people living with dementia, they can be more aware of those changes, report them to their doctors, and then the doctors can make referrals to the allied health specialists, dietitians, occupational therapists, speech language pathologists, who can support those people through those changes and once again optimize quality of life and nutrition.